No one found the eggs up here? Let's see. Okay, let's close that. Okay, I think that's everything. Oh, where'd they go? Where'd they go? Where'd they go? Okay, those of you on Zoom, which is quite a few of you, if you have a question, do not use the chat function because I won't see it. Well, I will see it, but I'll almost certainly miss it. So I can hear you just fine, I think. So just go ahead and voice your question and I will try to give you an answer. And if I can't hear you, then maybe text somebody in class or something. And I'll try to get your questions answered. I just, using the text function, I get this little prompt, but it's up at the top of the computer. And when I'm lecturing, I don't look at the top of the computer. I'm looking at what's going on. So I won't see it. So I won't miss it. If you have a question, just say something. First of all, can everyone hear me okay online?
Yes.
Yep.
You can, thank you, Sydney. Okay. And oh, Audrey, how's your dad?
He's okay.
So he, did I understand your email right? He's hospitalized
Yes.
and he's gonna be all right, it looks like.
We're hoping. He's struggling to keep his oxygen levels up.
Okay, is he on exogenous oxygen?
He is going between BiPAP and nasal cannula, and he's on 60 liters at 100% oxygen.
Okay, so a fair amount of oxygen.
Yeah, when he went in, his O2 was 44.
Okay, that's pretty low. All right, so.
Yeah.
Okay, so we'll pray for him this evening. And are you feeling all right?
Yeah, I feel fine.
You feel fine, okay. Just so you know, I know exactly what it's like to have a COVID positive person in the house and have to be on quarantine. Because I just got off quarantine, so. Okay, let's have a word of prayer, then let's dive on in. Lord, thank you for Easter, for a chance to get a few days off. Thank you for the empty tomb. Thank you for the empty cross. Thank you, Lord, for redemption so great and so free. We pray for every student online or here in class. Help us out to learn. We want to pray for Audrey's dad, for Mr. Morris. Please help his oxygen to get up, help his tissues to be oxygenated. And thank you for the good care he's receiving. Thank you for the terrific daughter he has and the great nurse she's going to be. And now, Lord, help us use this time wisely in Jesus' name. Amen. Okay, let's keep Mr. Morris in our prayers because as you can hear, he's not doing too well. All right, anticoagulants are the subject for the evening. So please take your handout. That's- no. Why do you keep? That's the one I want. Okay. All right. So last time we talked about warfarin. We talked about warfarin. So warfarin, remember, warfarin, you are declaring war on vitamin K. You're declaring war on vitamin K. And vitamin K is involved with the post-translational modification of what for clotting factors? Anyone remember? Go ahead, Shay. 10's one of them. Yeah, 10's one of them. What's the other three? 9, good. And there's 2 more. No. No. 7, thank you. And what's the last one? No. No. 2. 2, 7, 9, and 10. Everybody say that. 2, 7, 9, and 10. Say that with me. Factors 2, 7, 9, and 10. I can't hear you. 2, 7, 9, and 10. You online too. Let's hear it. 2, 7, 9, and 10. Go. 2, 7, 9, and 10. These factors have different half-lives. You have to inactivate all 4 of them in order for warfarin to become fully active. That's why it's going to take 3 to 5 days for warfarin to start working. So you can't give someone warfarin and expect it to work right away. They have to be on it for 3 to 5 days, the rough average being about 4 days. Reason being is that these factors have different half-lives. Factor 7 is a very short half-life. Factor 9 is a very long half-life. So 3 to 5 days. So that's why we talked about bridging patients with heparin. Remember that? We talked about bridging. Why do you bridge patients with heparin? Patients going on warfarin with heparin. Why do you bridge a patient going on warfarin with heparin? Heparin is an indirect thrombin inhibitor. It's not a vitamin K antagonist. Remember the skin necrosis we talked about? Shay, you're looking at me as if I'm from Mars. Kinda? Anyone remember the skin necrosis we talked about? Heparin will cause skin necrosis. Anyone remember why? What are the 2 regulators of the coagulation pathway? Factors, protein. Mnemonic, cows and seagulls. Protein. C, cow, and protein. S, seagull, cows and seagulls. So warfarin's declaring war on vitamin K, and vitamin K modifies factors, clotting factors 2, 7, 9, and 10, but it also modifies protein C and protein S. Protein C and protein S regulate coagulation. Protein C and protein S have very, very short half-lives. You inhibit those first. When you inhibit those first, you now start to clot in tiny vessels in the skin. That's why you bridge with heparin. Because after 3 to 5 days, the anticoagulant effects of heparin are now in full bloom and they overtake the procoagulant effects of heparin. That's why you always bridge patients going on to warfarin with heparin. All right? They're natural in your body. They also have to be vitamin K modified. And warfarin inhibits vitamin K modification also of protein cow and protein seagull. So warfarin at first is procoagulant, procoagulation. Later, when it inhibits factors 2, 7, 9, and 10, it becomes anticoagulation. That's why you bridge to make sure that you're into the anticoagulation effects rather than the coagulation effects. Now, can you see what a disaster then it would be for someone to just arbitrarily take themselves off their warfarin? Oh, well, then I'll get back on it. Sorry, chump, doesn't work that way. No, there's a protocol for getting you onto the heparin. That's why when they're on warfarin, they need to take it all the time. You need to take it at the same time every day. Same time every day. They forget a dose, if it's the same day, you just take it during the day. If they forget it's a whole day, you take your dose as soon as you remember and log it for your doctor. Okay, so that's with warfarin. Again, remember, warfarin is oral. It's oral. So warfarin is, it's PO. It's only given PO. It's not given intravenously. Heparin is only given parenterally. Heparin's given either IV or sub-Q. And if it's IV, then it's going to be a heparin drip. Very good, Jay. Heparin drip. Go ahead, Grace.
So it's the warfarin that injected, but it's the warfarin that inhibits protein synapse, which is what causes the skin to
Yeah,
and then that's why.
right. Because the small capillaries in the skin get clots in them. It's not so procoagulant that you get big clots in big vessels. It's only the small vessels where you start to get those clots. And the first tissue that shows the effects of that is the skin. So you always bridge them with heparin. So let's just say here, you bridge with, that means with heparin. By bridge, I mean you give them heparin first, you start them on warfarin orally. You keep them on heparin for 4 days. The big test, what's the big test for warfarin? Remember that test we talked about? You're right, the prothrombin test, but you're going to standardize it using the internationalized ratio, the INR. And what do you want the INR to be when someone's on heparin? No, 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 no. You want it between 2 and 3. Between 2 and 3. Good golly, great gee willikers. Maddie, 10. No, patient's gonna bleed to death. You're gonna bleed out right under your eyes. No, gosh, no. 100 lashes with a wet noodle. No. INR, you want it between 2 and 3. When that INR is between 2 and 3, then you take them off the heparin, they're on the warfarin now. Yes. You usually need to give them something. Unless sometimes people who get knee surgery, usually you'll give them heparin. They get off the heparin, but then maybe days or even a week later, they'll get a clot. They'll usually need to go on warfarin because for them to be on heparin for that long, to give themselves shots like that is too inconvenient. So they'll go on warfarin and then usually they'll just get stepped off the warfarin very slowly. You reduce the dose gradually. You always step off it. You don't stop it cold turkey. There's one ortho I talked to. He said he had a patient that he got them off warfarin really quickly, but that person was very young and very healthy and wanted to go back to exercising to get the knee. They were a professional athlete. So in that case, they dropped it cold turkey. Because if you got little clots, he'd deal with it. So yeah, okay. So that's the big review on warfarin. So the PT test, that's your INR. You're going to watch that between 2 and 3. So the big E, remember for warfarin, you're watching for bleeding. Bleeding. For all of these, you're watching for bleeding. And we'll talk more about that as we get into heparin. All righty. Questions on any or all of this? Any questions online? No? Okay. Then we will soldier forth. Let's now talk about heparin. So heparins are indirect thrombin inhibitors. Indirect thrombin inhibitors. These heparins will activate a natural protein in our blood and tissues called antithrombin 3. So antithrombin 3, it's a natural regulator of thrombin. Heparin binds to antithrombin 3 and supercharges it. So think of antithrombin 3 with a Superman cape if I could draw. I draw it, but I can't draw, so I won't subject you to that. So heparin, again, is always given parenterally. So heparin, let's use our little mnemonic. The name of the drug is heparin. So heparin comes as unfractionated heparin. It's usually abbreviated UFH. So remember, these are chains of complex carbohydrates. Unfractionated heparin will consist of long chains, kind of long chains, long-ish chains, kind of medium chains, medium short chains, and short chains. It's a mixture of all these different types of chains of complex carbohydrates. And this is secreted. This is not secreted renally, so you don't have to adjust the dose for patients according to their renal function. So no renal function adjustment to the dose. You just give this and it works and you don't have to worry about the renal function of the patient. Now, this is a heterogeneous product, so its pharmacodynamics and kinetics are not as predictable. And consequently, there's now a more synthetic product that consists essentially of chains that are all the same size. And this is so-called low molecular weight heparin. This has much more predictable pharmacokinetics. So this is Lovenox, Fragmin, enoxaparin is the trade name that's on your handout. So enoxaparin, there's also deltaparin, Fragmin. This is Lovenox. Lovenox is definitely the product that's used the most. There's another product called tinzaparin. Tinzaparin in studies worked very well, but the manufacturer, the trade name of tinzaparin was Inohep. And Inohep, unfortunately, the company couldn't make any money off it, so they stopped producing it. So these now are the two products in the US. Enoxaparin, deltaparin, bemaparin is used overseas. It's not used in the US, but it is a low molecular weight heparin. I'm sure you guys have seen this. Lovenox, yes? Okay, yeah, you've probably seen it. So this is given both SC, so people who have knee arthroplasty or even shoulder arthroplasty or something like that, they'll be sent home with a package of bottles of Lovenox. And one of your jobs as a nurse to instruct them how to give this SC and what have you, and that's important. And then, of course, you can also give it as a IV drip. Okay, so first thing about heparin that you have to consider. So there's the name, heparin. Oh, it stains through, so. Okay, so the use. So heparin is used for deep vein thrombosis. It can be used both for prophylaxis and for treatment. Both for prophylaxis and for treatment. What's prophylaxis mean? Excellent, good. Say that again, Grace. Prevention, very good, exactly right. Then it can be used for prophylaxis or for treatment. Usually the dosage for prophylaxis is just going to be a bulk dose. You can also use it for pulmonary embolism. Again, prophylaxis or treatment. Prophylaxis or treatment. You can also use it if you're putting in a stent. So for percutaneous intervention. It can also be used for ST elevation myocardial infarction. And you can also use it for unstable angina. And then non-ST elevation myocardial infarction, you can use it for that as well. If you're using it as an IV, heparin is a drug that's given by weight. So it's very important you have to get a weight on your patient. Very, very important. So for example, I just have some dosages here. I don't keep these in my head. So notice for prophylaxis, it's just a big bolus, boom. You give essentially this many units SC or that many units SC every 12 hours, so on and so forth. For all these others, look, it's per weight, per weight, per weight. So bolus and then per weight, per weight, per weight, per weight, per weight. So this is a drug that's given per kilogram body weight, very important. You get a weight on your patient. Secondly, heparin has to be titrated. How are you going to titrate it? You're going to titrate it according to the test called an activated prothrombin time test. Activated prothrombin time test. In this test, you take the blood plasma and you get rid of the calcium. And then you add back essentially your components to activate coagulation. So you're only testing for the intrinsic clotting pathway. Remember the PT test tests for the extrinsic pathway. And that when you just spin the blood down, it doesn't have any factor 7. You add your commercially available factor 7, the blood clots. And because the factor 7 available from different labs give you different time, there's a standardization time, you divide it by, and that's your INR. With this, essentially, there's no standardization needed. Now with this, normally, your time will be between 30 to 40 seconds. That is non-therapeutic. Your therapeutic time is going to be 1.5 to 2.5 times this. 1.5 to 2.5 times this. So your top time for APTT is 80 seconds. Your bottom time is 60 seconds. You're below 60 seconds. What do you need to do to your heparin? Raise it or lower it? Sorry? This says your blood is clotting too fast. If your blood's clotting too fast, your patient's at higher or lower risk for a clot? Higher. So your heparin dose needs to be increased. If you're out here, and you get questions like this on the NCLEX. They'll say, your patient's APTT is 120 seconds. What should you do to their heparin dose? Lower it. You should withhold the heparin, wait until their APTT gets back into this range, then restart it, maybe at a slower rate. Okay, is this clear? I see Sarah over there is ready to eat out of my hand. Sarah's getting it. Okay, Caitlin? Yeah, good. Clarissa? Yeah? Jay? Rest of you? All right, good. You guys online, any questions? Okay, what is the antidote for heparin? The antidote for heparin is protamine sulfate. I believe it is. Yes, it is. Number 3, reversal agent protamine sulfate. So heparin is negatively charged. Protamine sulfate is very positively charged. So the two go, they essentially end up hugging one another very tightly. They don't want to let go. And so the heparin can't work because it found another mistress, shall we say. Yes, it's a bit meretricious, I grant you that, but hey, if it helps you remember it, then maybe you'll remember it. All right. And there's some notes on there about how to administer protamine sulfate. You're going to try to calculate it. With unfractionated heparin, it's 1:1. 1:1. So use a meg for every 100 units of heparin. Max dose 50 mgs. And if you use more than that, their kidneys are going to complain. You use this as a guesstimate and then pray that it works. With low molecular weight heparin, you don't have to titrate it, usually. You don't have to do APTTs. However, APTTs can still be useful if you're trying to reverse it. Also, because with low molecular weight heparin, because the drug, the material has a very low half-life, very often you can just wait it out and the patient usually will be fine. All right, okay, so we got the name, we got the use. Okay, what are your responsibilities? Responsibilities as a nurse when your patient is on heparin. Let's talk about your responsibilities. So the biggie with heparin, of course, is going to be bleeding. So your responsibilities are, first of all, the titrate. Check the APTTs, but then the big side effect of heparin is going to be bleeding. Now, signs of bleeding. Bleeding can occur in some places that are very obvious, but most often it'll occur in places that are not so obvious. So if someone bleeds into their GI tract, it'll tend to make them sick to their stomach and they'll tend to upchuck. So you're going to look, the blood in the GI tract will usually dry up and it'll look like coffee grounds. So you get this condition called coffee ground emesis. Coffee ground emesis. If they upchuck and you see these things that look like coffee grounds, that says they are bleeding. Also, if you get black, tarry stools, this is called hematochezia. This is also called sometimes melena. In this case too, that says that they're bleeding also usually in the colon or something like that. That's something else to watch. The other place where you'll tend to get blood is urine. What color is the urine going to be if they're bleeding? Well, more usually pinkish, pinkish. So in this case, you have hematuria. And in this case, you'll be able to do a dipstick for hemoglobin, won't you? So you can dip the urine. In this case, you can use dipsticks with just about every hospital doctor's office is going to have. Because sometimes you can hold it up and go, because if your patient's on a diuretic, it might be really dilute, might be hard to tell. Don't guess, just get the dipstick and because there shouldn't be much blood in it anyway, right? So dipsticks. Now, other things that they're happening if they're bleeding. What's going to happen to their CBC? Right, so the reds are going to go down. And then also the other thing to watch is the hematocrit. Their hematocrit will also be tanking as well, won't it? You might also see other thing to watch for are the platelets. And I'll show you why in just a bit here. So you're going to be watching for coffee ground emesis, black tarry stools, blood in the urine. And the stools also, there's a test, guaiac stool test. You can order that guaiac stool test. That'll tell you if there's blood in the stools. That's also a strip you can insert into the anus and then pull it out and then send it to the lab. And the lab will be able to tell you if they're bleeding. Okay. Oh, I'll still- Now, if someone has been on heparin for a bit, usually after 3 to 5 days, sometimes they will get a immune reaction that goes like this. So if this is a platelet, they'll get there's a protein on the surface of the platelet. It's called platelet factor 4. And sometimes heparin will make a complex with PF4. And your body will make antibodies. Antibodies against this PF4 heparin complex. And this PF4 heparin complex antibody will bind, and then the FC portion will also bind to the FC receptor. So this will actually swing over and bind here. That activates the platelets. You get massive platelet activation throughout the body. And so this will cause clots throughout the body, and it will burn up your platelets. So you have thrombocytopenia. This condition is called heparin induced thrombocytopenia, otherwise known as HIT. Heparin-induced thrombocytopenia, otherwise known as HIT. So the antibodies to the PF4 heparin complex bind to the platelets, activate the platelets. You get this massive platelet activation, so you get clots all over the place. This will occur usually 3 to 5 days after the patient's been on heparin. You are at greater risk for this if you had prior exposure to heparin and if you are female. Yes, Grace?
Sorry, what causes this? Is this like a
No, it's not really hypersensitivity. The heparin binds to platelet factor 4 on the platelets. That complex is recognized by the immune system as foreign. They mount an immune response to it, and those antibodies that bind to the PF4 heparin complex on the surface of the platelets activates the platelets en masse. So no, it's not a hypersensitivity. Not a hypersensitivity. You see this more often with unfractionated heparin than you do with low molecular weight heparin. Now, if you have anti-platelet factor 4 antibodies in the blood, those are usually diagnostic for HIT if someone's been on heparin. And they start to see the signs of HIT. So for HIT, I'm going to give you this mnemonic. It's kind of dumb, but all my mnemonics are dumb. You know that by now. So You're a disappointment too. These are the 4 T's. The 4 T's. Okay, you ready? The 4 T's. So the first T, as you might guess, is thrombocytopenia. And in this case, your platelets will just crash, and they can crash quickly. That's why you need to be watching those CBCs. Two is going to be timing. So you get a fall in platelet count, usually 5 to 10 days after platelet initiation. So about 5 to 10 days. It starts usually 3 to 5 days, but the real drop will be 5 to 10 days. The other is going to be thrombosis. Thrombosis. The thrombosis usually will occur at the extremities. You'll see blackening of the tips of the fingers, blackening sometimes of the nose and the toes. So if someone has hit, where are you going to look first? Look at those nail beds. Those nail beds will be some of the first places you'll see the effects of hit. Look at the patient's toes. Look at the ears. Look at the end of the nose. Four, and this is the dumb one, no other explanation. Those are the 4 T's for hits. Thrombocytopenia, timing, thrombosis, and then no other explanation. Yes?
Would blackening, tips and toes and stuff, would that always be thrombosis?
That's usually thrombosis, yeah. It's, if your patient's on heparin, that's the first thing you should think of, unless they got some other reason to be having clots. Because they're on heparin, they shouldn't be having clots, but now they're having clots. So your head automatically should go to hit. And if you're watching those CBCs like you're supposed to, that drop in platelets is a big, big tip-off. Shay, do you see how important a medical history is? Because if they've had previous experience with heparin, right away that ups their risk. Okay, how do you treat hit? You get them off the heparin as fast as you can say Kalamazoo. So you're going to hold heparin. Hold heparin ASAP. Do not give them platelets. You give them platelets, there's anti-PF4 antibodies and heparin just lying in wait for them. You give them platelets, you're going to make it worse. So do not give them platelets. Thing you need to do is prevent the clotting. So you're going to use direct thrombin inhibitors. And the drugs you'll use, there's a drug called argatroban. This is definitely the most widely used drug for HIT. It's especially ideal for those receiving dialysis because it's not excreted by the kidneys. It's processed by the liver. This will inhibit thrombin, but it will also inhibit other factors. So it's a very effective drug. This drug was derived from research on the anticoagulant peptides found in the salivary glands of leeches. That's how this drug was developed, argatroban. The other drug that is used is also a drug derived from research on the leech. It's called bivalirudin. This goes by the trade name of, don't tell me, don't tell me, don't tell me. Angiomax, Angiomax. There is another drug you can give, albeit it's given off label, and that's fondaparinux. Fondaparinux is a factor 10 inhibitor. But unlike the other anticoagulants that are oral and inhibit factor 10, this is given parenterally. There was another drug called denaparoid. It was discontinued. It's no longer used in the US, but it's used overseas. So don't worry about that drug. Yes. I put them for HIT. You're very welcome. Argatroban and bivalirudin. Argatroban goes by the name Acova sometimes, but it's in generic now. Acova. Okay, any questions about HIT? Okay, so that was so the name of the drug is heparin. It's used for DVT, for PE, for PCI, that sort of thing. You've heard about your responsibilities. We talked about side effects. What's the next part? Education of your patient. Evaluation would be up here. So the other, now let's talk about education for your patient. So patient's going to be more susceptible to bleeding, right? So you tell them to minimize things that can cause bleeding. So use a soft bristle toothbrush. Soft bristle toothbrush. Also, if they shave, use an electric razor. Don't use open blades. Those will be more likely to make you bleed. No contact sports. If they are injecting heparin sub-Q, you're going to have to educate them on sub-Q injections. So with sub-Q injections, you want to inject 2 inches from the navel. And you want to be 1 inch away from scars. So you pinch, you insert, you release, and then you do not massage the area of injection, do you? No, do not massage afterwards. Don't rub it. Just say, don't rub it. That's very important. If you rub it now, it's got, you have a blood depot essentially in the sub-Q that's going to get absorbed gradually into the vasculature. If you rub it now, it's going to get worked into other tissues. Your release now is going to be erratic. Instead of a nice release of the drug, you're going to get this herky-jerky sort of thing, and that's, don't rub it. and then demonstrate it for them if need be. Also, avoid IM injections. You avoid IM injections because you give them IM injections, it's going to cause bleeding. So try and avoid IM injections. My M, I realize, is there. Looks like it's on drugs. If people are on heparin long-term, there's a risk of osteoporosis because heparin upregulates osteoclasts, the cells that reabsorb bone. So that's a long-term effect. They're on heparin for a few weeks. That's not going to be an issue. That'll be more of an issue if we use it long-term. Okay. Now let's see how well you all paid attention. Okay. Number one. Can you guys see that? Or is that too small? No. Better? Now can you see it? Okay. So heparin's an anticoagulant. What family of anticoagulant medications does heparin belong to? Let me. There. Is it a direct thrombin inhibitor? Is it an indirect thrombin inhibitor? Is it a vitamin K antagonist or a factor 10? Okay, who says factor 10? Okay, who says vitamin K? Who says indirect thrombin? 1, 2, 3, 4. Who says direct? 1, 2, 3. That's correct answer. It's indirect because it inhibits it via antithrombin. Great. So it's an indirect thrombin inhibitor. Indirect thrombin inhibitor. Okay, which statement best describes how heparin works as an anticoagulant? A, it inhibits clotting factors from synthesizing vitamin K. It activates the extrinsic pathway of coagulation, prevents factor 10 from activating prothrombin to fibrinogen. Or D, it enhances the activation of antithrombin 3, which prevents activation of thrombin and the conversion of fibrinogen to fiber. Who says A? Who says B? Who says C? And who says D? And all of you are right, the answer is D. Very good. Okay, which patient below would be the high risk for developing adverse effects of heparin? What's the adverse effect of heparin? Bleeding. Bleeding. I say adverse effect, no. It is a potential complication. It's not a side effect, it's a potential complication. So think bleeding. You're to high risk, bleeding. Select all that apply. 42-year-old female with uncontrolled atrial fibrillation. That person at risk for bleeding. Atrial fibrillation puts you at risk for clots because you get pooling of the blood in the atria, right?
When blood pools, it clots.
When blood pools, it's clots. Grace, you're a genius. So, is this person at risk for high risk for developing adverse effects of heparin? No, they need heparin. They need heparin. 36-year-old male patient with active peptic ulcer disease. What do peptic ulcers do? They bleed. What's an adverse effect of heparin? So is that patient at risk? You bet your toenail published. "45-year-old patient with a pulmonary embolism. Are they at risk for bleeding? No, they need heparin. They need heparin. Oh, by the way, will heparin dissolve clots that are already in place? No. Write this down. It prevents clots. It does not affect in situ clots. It prevents clots. It does not affect clots that have already formed. So that's a survey says 55-year-old patient who's post-op day 1 from brain surgery. What does surgery make you do? Bleed. What is an adverse effect of heparin? Bleeding. So that, yes or no? Yes. Good job. You guys are just brilliant. Okay, patients on a heparin drip. You administer a bolus of heparin. Start the drip protocol as ordered by the primary caregiver. Next important nursing action is collect the PT, 6 hours per protocol. Collect an INR, 4 hours per protocol. Collect a troponin, level 6 hours per protocol. Collect an APTT in 6 hours per protocol. And keep in mind, different hospitals have different protocols. What's the first thing? To titrate heparin, what's the test you use? APTT. Which one has APTT? That's one. Patient is ordered to start. Well, I'm not sure the patient's ordered to start. The nurse is ordered to start a continuous IV drip on a patient. Yeah, you're a patient. Start that for me, would you? Yeah, okay. Oh, can't quite find it. Prior to starting the medication, the nurse would ensure what information is gathered correctly before initiating the drip. Wait. Very good. You guys can be my nurse anytime. Patients receiving continuous IV heparin. In order for the medication to have therapeutic effect on the patient, the APTT should be 30 seconds to 40 seconds. If you're being treated, it should be 1.5 to 2.5 times the normal range. 60 to 40. 60 to 40. Sorry, 60 to 80. 60 to 80. I got it. 1.5 to 2 times normal range. 30 to 40. Okay. What is the normal level for activated partial thromboplastin time, APTT? 30-40, good job. A patient receiving continuous IV heparin has an APTT of 105 seconds. Is that too high or too low? Or just too high. So what do? Increase the drip. Continue the infusion. No. Redraw. Yes. Hold it. Hold it and decrease because it's too high. They're at risk for bleeding. Select all the true statements about the medication heparin. Heparin can be used during pregnancy, yes or no? Yes, it's the one anticoagulant that you can use during pregnancy safely. Heparin does not pass the placenta. Also, when you're pregnant, you start hyperproducing clotting factors. That's to prevent you from bleeding to death while you're pregnant so that you don't bleed to death and kill the baby too. It's your body trying to protect you and the baby. So you have a hypercoagulated state. Some women during pregnancy can get clots at the placenta or can get clots that end up in the umbilical cord, especially during delivery. So they're given heparin, because heparin does not pass through the placenta. So it's safe during pregnancy. Heparin has a short half-life, yes or no?
Yes. Yeah.
Yeah. Heparin works to affect the intrinsic pathway. That's correct too. That's what APTT measures. That's what the activated partial thromboplastin test measures. Heparin can be administered orally, intravenously, or subcutaneously. No, it's not oral. It's not oral. No. Okay. Your patient is discharged home. Will be required to self-administer SC heparin. You're observing the patient administer their scheduled dose to confirm that he or she knows how to do it correctly. What action by the patient requires you to re-educate them about how to administer heparin? So you're re-educating them, that means they're saying something wrong, right?
Right.
They're saying something wrong, okay. Patient injects a needle into the fatty tissue of the abdomen. Fatty tissue, that's the SC, that's the sub-Q, right? So they're actually administering it correctly, right? So you don't need to re-educate them. So it wouldn't be A. What about B? Patient injects an inch away from the umbilicus. How far should you be from the umbilicus? 2 inches. So that one you need, right, 1 inch. Say it with me. 1 inch from a scar, 2 inches from the, come on. 1 inch from a scar, 2 inches from the umbilicus. If you say it, sometimes you remember. So that one's correct. That one, they need to be re-educated. C, patient rotated injection site from previous doses of heparin. Should you rotate injection sites? Yes. Yes, you should. So that's good. No, I actually forgot to say that. So the patient does not massage injection site. After, should you not massage injection site?
Yes.
Go patient. So do you need to re-educate them? No, so really that's the only one you need to worry about. Okay. Patient is on a continuous heparin drip. As the nurse, you're monitoring any adverse reactions. Select the signs and symptoms. Indicate this patient's having an adverse reaction to this medication.
Bleeding.
Hematuria.
Yes.
Yeah. Decreasing platelets. Increased blood glucose. That anything to do with heparin? No. So that, yeah, no. Low hemoglobin hematocrit. That says they're bleeding. That says they're bleeding. Positive school Guaiac test.
Yes.
Yeah, so it's all those except for that one. So let's go ahead and. These, by the way, are old NCLEX questions. Your patient, oh gosh, I got that too. Patient on heparin develops HIT. What signs and symptoms in the patient confirm this diagnosis? Select all that apply. Which you're going to have a decrease or an increase in platelet levels? Decrease, very good. Development of a new thrombus. Yeah, that's a clot. Because you activate the platelets, you activate them now on your CBC because the platelets have stuck to something, they don't come out in your CBC. So your platelet level is going to tank. Development's a new thrombus, because you've activated platelets, you're going to get new thrombi, aren't you?
Yeah. Is that the black tips of the fingers?
Exactly, exactly. Increase in hemoglobin level. No. Okay, patient develops HIT. As a nurse, you expect the heparin to be discontinued. Patient be started what other type of coagulant, anticoagulant? That's the antidote for heparin. You're gonna get the antidote for heparin. You need to do something about the clots. What are you gonna do about the clots? And argatroban is a direct thrombin inhibitor. Very good. Don't give warfarin, that takes too long. It takes way too long. What's the antidote for heparin? Protamine sulfate. Da, da, da. You're providing care to patients been on long-term doses of heparin. What finding in this patient demonstrates patient may be experiencing a complication that can be due to long-term effects of this drug? Good job, Shay. Bone fractures. Oh, I got something wrong. Oh, did I check? Oh, you know what? Because I pushed my up and down, and I think it changed the answer to, that's okay. You guys know what the answer was. So, okay, good job. Good job, everyone. You should be proud of yourselves. Okay. All right, let's take a break. We'll come back and talk about antiplatelet drugs. We should be able to do those lickety split. And then, yeah, so take a break. Look for some more eggs if you want. There's eggs up here. Oh.
What? Oh.
Unless you really want them. You don't need them, then my wife will take them because she, we see that Sunday school lesson with the resurrection Aggies?
I don't know.
Fire?
Have you not smell smoke? Even I smell.
Oh,
Yeah,
you
it's like
smell
butter.
smoke.
Even I smell it. You do? Yeah. Are you gaining your senses? I think I do. After a good 2 months. After 2 months, fine. No, not like that. Not nice. Yes.
Well, the sky finally cleared up. It was
It's supposed to be like 80 degrees. And I'm gonna be at the hospital. Oh, I'm gonna be outside.
You know, guys, when the weather gets nice, I have no problem being outside.
Ooh, really?
Oh, yeah. I have no problem being outside, especially as the days get really long.
I would do that. Oh.
I will just drag, Aaron's got that blackboard in his room, just drag the blackboard outside.
Oh, yeah. That'd be so fun. That'd be nice. Let's do it.
Yeah,
Yay.
after being inside all that for all that time, so.
I got it. What? That's.
And you guys missed the two back there.
Oh. There's one on the floor. I'm taking. I'm getting her to this. Dr. B, I have a question for you.
Yes.
About ranitidine. Ranitidine, you know that drug? I'm letting you.
Which one is this?
Yeah.
Because of drug.
Okay.
Thing is, ranitidine is still on the market. That's got a lot more drug interactions than ranitidine.
Yeah, well, that's a
It's What I think they should do is just pull it over the counter sales. Make a prescription.
That way you can.
Because it was
regulate
prescription at one
your
time, yeah. It was prescription at one time. and it's not anymore.
Yeah.
Those drugs, the H2 inhibitors have already been replaced
Someday I
by
will.
proton
Yeah.
pump
Someday you will. I'll be coming.
No, I think it's efficient elections. Proton pump inhibitors are very efficient.
They're better, they're better at.
They lower stomach acid
Yeah.
a bunch. And some people don't need that much lower. So they do better on the H2 inhibitors. So I personally think patients do better when they have options. That's my personal thing.
I'm
So-
excited. Clap for me? Thank you.
I didn't really thought you said that, but yeah, I was like, oh.
Okay, gang, it's ready for us. We need to start up again. All right, so remember, coagulation consists of these two parts where you have activated platelets and you make the platelet plug. We talked about that last time. And then you reinforce the platelet plug with the production of fibrin. And we talked a lot about fibrin formation, preventing fibrin using both oral and parenteral anticoagulants. Remember, anticoagulants prevent coagulation in veins, whereas your antiplatelets are going to mainly be concerned with clots in arteries. Do I need to go through the steps of platelet activation again? No? Remember those all right? Okay. So let's talk then about essentially the drugs involved with platelets. Okay, the first group involves this platelet activator, adenosine diphosphate. Adenosine diphosphate binds to a receptor, and so you have a group of antiplatelet drugs that are adenosine diphosphate receptor antagonists. And you have a list of those drugs on your handout. So notice that two of them at least end with grel. So clopidogrel and prasugrel. Clopidogrel is a drug that was marketed as Plavix. So I'm sure you guys have heard of Plavix. So that's clopidogrel. Clopidogrel now is available as a generic. It's been available as a generic for quite a while. It's a very inexpensive drug. It's the weakest of this group. Because it's the weakest of this group, if you have someone who doesn't need that much antiplatelet activity, it's a very good drug to put people on. So this receptor is called the P2Y12 protein. And so these are P2Y12 inhibitors. So there's clopidogrel. Clopidogrel is a prodrug. So it has to be metabolized by the liver. It's a prodrug. It has to be metabolized first by the liver. Second drug is prasugrel. This goes by the trade name, not Brilinta. Effiant? F something, Effiant or something like that. Anyway, Prasugrel. Effiant. I was right, Effiant, okay. Effiant, yeah. This is not yet in generic just yet. It'll be under generic probably soon. These two drugs, they bind to the receptor irreversibly. So these are irreversible inhibitors. Now, why is that significant? Remember, platelets don't have nuclei. They can't remake their receptor. So the only way you fix this in a platelet is by making new platelets. That means you will inhibit platelets and you only relieve yourself of that activity as platelets are remade. So it'll take essentially about 5 to 9 days for the effects of these drugs to fully wear off. And both of these are prodrugs. They bind to the receptor. They form a covalent adduct with the receptor. So now the platelet is incapable of being activated by ADP. So remember, platelets only live 5-ish, 9-ish days in circulation. So they have to be replaced before the effects of the drug fully wear off. Now, there's another drug that's also oral that's not an irreversible inhibitor, and that is ticagrelor. This doesn't end in grel, unfortunately. This is a different name. This is Brilinta, grel. Brilinta, I think, Brilinta, something like that. I don't remember. This drug is also given orally, but it's going to have, this drug is also not a prodrug. So this drug is going to work faster, but because its effects are reversible, this is reversible. Because it's reversible, then it is going to bind to a receptor, to the receptor elsewhere. And once you get off this drug, essentially the platelets go back to normal right away. It's not like these drugs where it takes a while for the platelets to get back to normal because the platelets have to be remade by the bone marrow. So if you need somebody to be on antiplatelet drugs for a short period of time and you want them to go back to normal because they have a procedure, something like that, this drug might be a good choice then. Now, the other drug that's not on here is a drug called Congrelor. Congrelor has a very short half-life, 3 to 6 minutes. This drug is not given orally. So this drug is given parenterally. And it's going to be used largely for percutaneous intervention stents. When people are given stents, that's usually when Congrelor is going to be given. This is the newest of that group, Congrelor. The first 3 of these are all oral. Prasugrel, clopidogrel, ticagrelor, they're all oral. Congrelor is not. Congrelor? Yes, parenteral. Usually given IV. You can give it SC, but it's usually given IV. So it'll be given while the patient's on the table and the cardiologist is putting the stent in. Now, these ADP receptors very often are given in combination they're very often given in combination with aspirin. And so they are very good for people who have acute coronary syndrome. And that's one of the places where these are used. So acute coronary syndrome, remember, if you have an NSTEMI or if you have unstable angina, that's an acute coronary syndrome. That's where these get used. Clopidogrel plus aspirin is very often used as a pretreatment for people undergoing stenting. So that's a pretreatment for those who are undergoing stenting, PCI. And during stenting, it is rather common to use groups of medications that are also antiplatelet, but these prevent the glycoprotein that binds to fibrinogen and binds the platelets together. So these are the glycoprotein 2B, 3A inhibitors. All of these are given parenterally. These are pretty powerful drugs, these three drugs. So there's three you have on your handout. There's eptifibatide. Please don't say that after you've been to the dentist. Eptifibatide. And that's given intravenously. Virtually all these are given intravenously. Can also be used for acute coronary syndromes, but it's used mainly for stenting. You then have this other one, and my dumb mnemonic for this one, think of a flat tire, because it's tyrofiban. That goes by the trade name Agristat. Also usually given IV. Then you have a drug that's a monoclonal antibody, ipsiximab. I killed that. Ipsiximab there. Ipsiximab is an antibody. The thing about this drug is that the manufacturer stopped making this drug. So many cardiologists I've talked to really like this drug because it will last in your system for up to 2 weeks. So after stenting, you get 2 weeks of anticoagulation, which is really good while the stent is essentially being grown into. Many cardiologists really like that, but this has been discontinued because the manufacturer couldn't make any money off it. Antibodies are very expensive to make, and I'll just give you the data and let you draw your own conclusions. When a drug company is being reimbursed solely on the basis of Medicare and Medicaid, Medicaid and Medicare remuneration is below the profit margin of the company. And if you're constantly being remunerated on Medicaid and Medicare, you're not going to make enough money to recoup your funds for making the drug, distributing the drug, and what have you. So if that drug is consistently losing the company money, they're going to discontinue it. And that's the case with this drug, because most people who need it are on Medicaid and Medicare. So it's not that I'm anti-Medicaid, Medicare. It's just sometimes I wish Medicaid, Medicare would remunerate their drug companies better, so that they'll actually keep drugs, have more motivation, keep drugs in circulation, because drug companies, they're a business. They have to make money. They have bills to pay. So anyway, oh, those greedy drug company, 4-letter words, blah, blah, blah. You read it all on Twitter. But keep in mind, folks, without them, we wouldn't have the drugs that we have. It's just that simple. All right. So those are antiplatelets. Then there are 2 more drugs, and these are phosphodiesterase inhibitors. Phosphodiesterase inhibitors. Now, what are these for? So when platelets are activated, platelets normally have cyclic AMP inside the cell, and cyclic AMP tells the cell everything's IIIb, basically. So when you break down cyclic AMP, now the platelet gets activated. And the enzyme that breaks down cyclic AMP is called phosphodiesterase 3. So what do you think happens if you inhibit phosphodiesterase? You don't activate platelets. You get an added bonus with this too. You also get vasodilation. Now, why on earth is this a good thing? Well, what if you have peripheral vascular disease? My dad had this. So you usually get it in your legs. You get atherosclerotic blockage of the legs. You can't get blood down to the legs. And so you get this condition called intermittent claudication. And my dad, God bless him, God rest his soul, he loved to golf. To golf, you need to walk 18 holes. Dad would get to about the 12th hole and said, man, my legs are killing me. I can't go on much. What is going on? He used to be able to walk 18 holes. Now, what's wrong? And I said, Dad, you probably have peripheral vascular disease. Oh, what's that? My dad had very salty language. He was a farmer. I'm leaving out his modifiers. I said, well, Dad, you shouldn't have smoked so much. And you should give up cigars. Oh, 4-letter word. And so I went to the doctor, and the doctor said, yeah, Mike, you've got peripheral vascular disease. So he had recanalization surgery. And he was able to walk 18 holes again. And he got cancer and he died. Anyway, so these drugs essentially vasodilate, and they prevent this additional activation of platelets that comes with this blockage. So these drugs, and you have some of the names. of these drugs. There's xylostazol. That goes by the trade name of Pletal or Pletal, depending upon where you put the accent. There's another one used, not used quite as much. It's called pentoxifillin. Pentoxifillin is in a generic. These are sometimes used with aspirin. Then there's another drug that is not used on its own. That's called dipyridamole. That should be a P, dipyridamole. Dipyridamole, if it's used alone, it's used for stress tests. But dipyridamole plus aspirin used to be called Agrinox. Let's just try that again. Agrinox. Now it's in a generic. So it's this combination of dipyridamole and aspirin, and this is used a lot for atrial fibrillation. It's a very, very good drug combination, very well tolerated, gives very, very good clot relief for people with atrial fibrillation. Okay, any questions about any or all of that? I have one egg left for those of you who are collecting the kisses inside. Those of you on Zoom, I'm sorry, I gave Easter eggs to the people in class. So some of them have your Easter eggs. I think they'll probably eat the chocolates before long. So sorry about that, but hey, that's what you get for coming to class. You get Easter eggs. So we will reconvene. We'll talk about clot busters. We'll take a look at anemia, and then we'll be done with cardiovascular. Hip hip hurrah.
Do you have any more of those sheets that you gave out before class? Just so I can bring one to Natalie. Thank you very much.
Would you mind sending the packet from tonight in an email to us on Blackboard? Yes, I can do that.
Thank you.
Right.